Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and I'm very excited to have the first author and senior author of the SHAM-PVI trial, Drs. Dulai and Dr Veasey, and I'll let them introduce themselves.
Hello, I'm Rick Veasey. I'm a consultant cardiologist and electrophysiologist in Eastbourne General Hospital. I was the principal investigator and lead author for the SHAM-PVI study.
My name's Dr Dulai, and I am the lead investigator and first author of the SHAM-PVI study. I'm currently an electrophysiologist at the Essex Cardiothoracic Centre.
Thank you for joining us, and why don't one of you give us the lead results of this SHAM-PVI trial, the first proper sham-controlled trial of AF ablation versus a placebo procedure. And I have been calling for this for 10 years, and I'm really excited to talk to you both.
So the SHAM-PVI study was conducted at two centres in the UK, Eastbourne General Hospital and the Essex Cardiothoracic Centre. The main results of the study was that we saw a significant reduction in AF burden with AF ablation compared to a sham procedure. And this was accompanied with substantial improvements in symptoms and overall quality of life.
Many of our colleagues have said such a trial is not necessary because clearly AF ablation works. So tell us what you were thinking about and how the conversations went in the planning of this.
This was a study I'd had in my head for sort of 10 years or more, perhaps like yourself, that it sort of needed to be done. We've all seen multiple patients who have had AF ablations where they come back to clinic feeling fantastic, but still clearly in atrial fibrillation. And the benefits from a placebo procedure are well documented, throughout the decades for medicine. And it's really the gold standard test of an intervention, a procedure, a therapy that we're able to offer people to do a placebo-controlled study. I think this is something we need to be doing more and more in medicine so that we properly see the effects of what we're offering to patients, not only because these are treatments that come with risks, but they also are treatments that come with quite considerable cost implications for healthcare services. It was a sort of study that was a bit of a slow burner for us. I had the idea of this study, but I didn't have a research fellow myself. And Raj's primary study that he was employed to do sort of fell through. So we ended up with a study with no research fellow, a research fellow with no study to do, and the pair married together really very well. And it was sort of 2018, 2019 that we really got the ball rolling, went through the ethics process. We started the study about 6 months prior to the COVID pandemic, and we'd put the first 10 to 12 patients through the study, but then had to stop for, I think it was at least 18 months and overcome that obstacle before we were able to get it finished. But there's been a lot of debate about the primary endpoint of the study, measuring AF burden versus symptoms. 10 to 5 years ago, that was still how AF studies were designed. It was all about, measuring the AF burden, and that's the sort of gold standard of these studies. We've also previously done studies trying to assess symptoms and symptom improvements with various treatments in atrial fibrillation, and really struggle with power calculations because they're harder to do and harder to estimate the effect of a placebo intervention. Going forward, we've actually now got a good estimation of what sort of symptom improvement you might expect against a placebo procedure.
Okay, so one group gets a cryoballoon ablation, which is a typical way to do AF ablation. And then you decided for the placebo procedure to do vascular access and sedation and phrenic nerve pacing. Was there a discussion about how adequate that was for a placebo procedure? Because some people have suggested that a transeptal placebo procedure might be a better placebo. Would you comment on the choice of the procedure and the placebo?
We spoke to patients who had had catheter ablation procedures before and sort of surveyed what are the things that they remember from their ablation procedure. And the phrenic nerve pacing was the was the number one thing that sort of stands out in terms of a sensation and an awareness that patients have had something done. So we went for the phrenic nerve pacing in both groups and as part of the placebo procedure. We didn't particularly look at doing the transeptal. We really wanted to keep the placebo intervention as low risk as possible. And we reviewed that with several cardiologists and electrophysiologists and felt it was a reasonable sham to offer people to compare AF ablation against.
Yeah, so when we were designing the study, it was designed with patient input. What they felt was the phrenic nerve pacing. So we went along the route of trying to simulate that cryoablation procedure whilst minimizing risk. So, and also I would add that if you look at the data, there are 2 patients in the ablation group who did not have an ablation because of issues with the transeptal. So we felt that that risk to the placebo group would not be warranted. If you look at blinding immediately after the procedure, it was near perfect. Patients were unable to guess which procedure they had.
For listeners, I'll just say that phrenic nerve pacing is used in cryoballoon ablation as a standard to study for phrenic nerve injury. And so it causes jumping of the diaphragm, and patients feel that. I understand why a transeptal wasn't done for safety reasons. Tell us about the patient population, because one of the interesting things with this trial is that a large number of patients improved in the placebo arm. 80%, I think, of patients had persistent AFib and had cardioversion. Would you comment about the patient selection and improvement in the placebo arm?
Yeah, so the inclusion criteria was those patients with paroxysmal or persistent atrial fibrillation, despite a class 1 or 3 antiarrhythmic, including beta blocker use. We had some exclusion criteria, including long-term persistent atrial fibrillation, patients with severe systolic dysfunction. Patients recruited, which I think is more reflective of our patient population, and when people are being referred for ablation, actually turned out to be the majority were persistent atrial fibrillation. So around 80% of the population were persistent. Average age was in the late 60s. And the majority of patients had tried a class 1 or class 3 antiarrhythmic before. And when we designed the study, one of the most important things was that when they leave the cath lab, they had to be in sinus rhythm, so a normal heart rate. Otherwise, everyone would have just guessed they've had an ablation or not, and you wouldn't have a blinded study. So the way we designed the study was that we did a stratified randomization according to type of atrial fibrillation, so that the number of persistent atrial fibrillation patients and paroxysmal atrial fibrillation patients were the same in each group. And those patients who were in atrial fibrillation at the time of the procedure, so the persistent atrial fibrillation patients, were cardioverted as well. Both groups had an equal number of cardioversions, and then they went on to have their cryoablation or sham procedure. And we did see a reduction, as you mentioned, in AF burden in the sham group, and we think that was mostly due to the intervention of the cardioversion.
SHAM-PVI, Orbita 2. Why do these very bold, brave, placebo-controlled trials come from the UK? I'm not sure that American patients would go for this. Perhaps it's the way we discuss things with patients. How does this happen in the UK?
We generally find, certainly in Eastbourne, that we have quite a high uptake of patients into our research studies. They particularly liked getting the loop recorders implanted. They like the degree of attention that comes with that. We don't advertise this as benefits of taking part in research. We explain what the study is. Throughout the years, we've done a lot of research in Eastbourne, and we've had very good uptake of it. I think the difficulty in other healthcare settings is the funding of, particularly in the US, you're paying for a procedure. Who's going to pay to have a placebo procedure? Who's going to fund the hospital? We had access to funding to cover that with ourselves. I think the difference is in the health systems facilitate research in the UK quite well.
Can I ask you just to comment on the conclusion, at least at ESC, that this completely ruled out any placebo effect? Do you think it completely rules out a placebo effect?
I agree it doesn't completely rule out a placebo effect, because you'd then need a placebo procedure against nothing, against intervention. But it clearly shows that there are benefits way above a placebo effect for patients who are referred for catheter ablation. So there's clearly something different from our placebo to our intervention that gets rid of your atrial fibrillation and improves your symptoms.
I would say this is one of the few trials that has a hugely positive primary outcome. And if you look at all secondary outcomes, whether it's the AFETQ, whether it's the MAFC questionnaire, whether it's the SF36, whether it's time to atrial fibrillation, every single secondary outcome is in favor and correlates with the reduction of AF burden that we see in the primary outcome.
I agree. I really appreciate that you took the time to come on and talk with us about it. And I really congratulate you on planning this, getting it done, and showing everybody that there is a placebo-resistant effect to AF ablation. And thank you.
Pleasure. Thank you.
Thank you.